The atrioventricular nodal block procedure is done with a diagnostic tetrapolar catheter placed in the right ventricular apex and a 4 mm irrigated tip catheter. The pump setup is 20 ml per minute with a maximum power of 39 watts and a maximum temperature of 40 centigrade degrees. The catheter we are showing is the Cool Therapy Duo by St. Jude Medical, which has a double row of irrigation holes on the tip to make the lesion safer and deeper, reducing the surface heating. The best way to perform AV nodal block is to look for the most proximal level of block. The proximal His is located where the AGM amplitude is at least 1/3 of the ventricular deflection. And of course, the atrial potential is also visible. On fluoroscopy, the ablation catheter has to be in the upper and posterior aspect of the interventricular septum. During RF delivery, junctional beats are evoked, and usually complete block is achieved in a few seconds.
Even when AV block is obtained, we prolong RF delivery for a minimum duration of 60 seconds. After the ablation, it is possible that AV conduction reappears. For this possibility, we usually wait 30 minutes and periodically reduce the paced heart rate to see if AV conduction is present over 40 beats per minute. After the confirmation of AV block persistence, we can remove the catheters and consider the ablation successfully accomplished. The proximal extremity of the lead is rolled and placed behind the can of the device. The pocket seems to fit the device and the leads very well. Fluoro check is made to confirm the stability of the leads and the good positioning. LAO view remarks the wide space between the electrodes. RAO projection shows the stable position of the CS lead distally in the anterolateral vein and the nice mid-septal position of the right ventricular catheter. It's now the moment to make again electrical test and to set Brady and Tachy parameters on the device. The first attempt to select the ventricular stimulation settings is the St. Jude Medical Quick Op test. This test evaluates the timing between the paced stimulus and the electrical signal on the other lead. Quick Op, in this case, suggested simultaneous pacing as the best configuration. The 12-lead EKG recorded after the ablate and pace procedure showed atrial fibrillation with VVI pacemaker-induced rhythm at 65 beats per minute. QRS duration is 130 milliseconds and QRS axis is 120 degrees.
This night the patient will receive low doses of unfractioned heparin. The oral anticoagulation therapy will start as soon as the stitches will be removed. Acetyl salicylic acid will be added to the actual therapy to dissolve the left atrial thrombus.
In this case, ejection fraction remains constant in all tested pacing configurations. Optimization is done repeating systolic performance indexes and asynchrony evaluation using different pacing configuration. Velocity time integral was not affected in whatsoever matter by different VV intervals. Time to peak systolic velocity showed a better intraventricular synchrony with simultaneous stimulation. Mitral regurgitation remained constantly mild to moderate with all tested pacing configurations. As summarized in the FastPath summary report, final pacing configuration is VVIR with 65 beats per minute of lower tracking rate and simultaneous ventricular stimulation. To minimize the risk for inappropriate DC shock, a single window under 300 milliseconds is set for ventricular fibrillation treatment. The device will perform automatically, if possible, sensing, impedance and pacing tests for the ventricular leads. Actually, mitral regurgitation remained mild to moderate. Ejection fraction improved to 50%. The volume overload was markedly reduced. Velocity time interval improved at the first follow-up after 2 months, considering the acute evaluation after AV node ablation as baseline. Transmitral and myocardial early diastolic velocities ratio and the absence of systolic reversal pulmonary vein flow in the acute phase demonstrate normalization of diastolic function of the left ventricle thanks to the AV node ablation and CRT pacing. The aortic and pulmonary projection time evidenced a good interventricular synchrony. Finally, standard deviation of mechanical contraction between 12 segments evaluated on real-time 3D echocardiography showed a non-significant level of desynchrony due to posterior wall motion abnormalities. This patient is clearly a responder to ablate and CRT pacing. A very intriguing possibility is the remote follow-up for CRT implanted patients. The result of the clinical evidence of the implantation and the direct follow-up, together with the remote monitoring, are stored into a virtual patient file, assuring a complete overview of the actual condition and the history of the patient anywhere. Intensive monitoring can result in reduction of healthcare expenditure and improvement of the quality of life for the patient. Hemodynamic improvement and optimized electrical and pharmacological treatments can lead to a consistent reverse remodeling of the left ventricle and the left atrium. If these improvements revert the staging of atrial fibrillation also, CPVA can be considered for this patient. Sinus rhythm has to be searched if possible because of the positive impact on the prognosis of further improvement of the systolic and diastolic function, the physiological sinus chronotropism, and the control of stroke risk.